to speak up, that's fine. خلاص كويس, it's good إنه recorded. If you would like to ask questions by voice, I don't mind. ممكن to raise up your hand, وافتكر أنا بشوفها هنا برضه. تمام؟ يلا ممتاز. It's a good number, 93. We just kick start now. Let me. This is first introductory slide. خليها أعملها full screen. I'll make it a full screen. So the title of the talk is Overview of Common Endocrine Disorders. Okay. This is our hospital. طبعا اللي هي King Abdullah Specialized Children Hospital. It's very big hospital in the Middle East. ويعني it includes all the subspecialty of pediatrics. طيب the endocrine glands يعني احنا if we start from خلينا اشيل دي بس بعيد شويه كده. How can I take this from the way? Good. طيب good. الآن we have the pineal gland. طبعا the main endocrine glands are the pituitary, guys, and also called hypophysis. Okay, so that's why you hear sometimes adenohypophysis. That means the anterior pituitary. And the neurohypophysis is the posterior pituitary. And they called like this because the embryological origin is different. So the neurohypophysis is coming from the nervous system. Adeno from the base of oropharynx. Then we have the thyroid gland, and we have the parathyroid glands, 4 of them at the back of the thyroid gland. And we have the thymus. It also has got, like the pineal gland, has got some endocrine function. Again, it's not one of the main. The main are pituitary, thyroid, parathyroid, adrenal, sex organs, and the pancreatic cells. The pancreatic islets or gland. So, and here this is the endocrine part of the pancreas, and there is exocrine part of the pancreas. And we have the adrenals on the top of the kidneys, and we have the ovaries or testes. طيب there are 3 levels of control, or we call them axes. So the plural of axis. And the first level, which is a tertiary level, is at the level of the brain. The hypothalamus has got control on the pituitary gland, anterior and posterior. And then the pituitary gland is called the master gland, which send messages to other glands in the body. And these glands are the thyroid, the adrenal gland, the different tissues that respond to growth, and then the sex organs. And then we have the breast tissue, the prolactin, and then we have the posterior pituitary has got hormones that works on the kidney and also on the muscles of the uterus and muscles of lactation in the breast. So we have the TSH, and above that we have TRH, and ACTH, we have above that CRH, and then we have the growth hormone, and above that we have the growth hormone releasing hormone, and then we have the gonadotrophins, and then we have on top of that gonadotrophin releasing hormones, and we have the prolactin, and before that we have the prolactin inhibitory factor and prolactin stimulatory factor, and we have the ADH primarily produced in the hypothalamus, and also the oxytocin, and is stored in the posterior pituitary, then secreted and in the appropriate times to control water homeostasis, or during pregnancy and during delivery or time of lactation. So the anterior pituitary secretes 6 hormones coming from 5 cells. The first is the thyrotrophs that secretes TSH, that stimulates thyroid to secrete thyroid hormone, T4, which change in the tissue to T3 as well, T4 and T3. And then the corticotrophs that secretes ACTH, that stimulates the adrenal cortex to secrete cortisol, while the aldosterone from the cortex is under the control by the renin-aldosterone system, juxtaglomerular apparatus in the kidney. And then we have the growth hormone is a hormone directly secreted from the anterior pituitary from the somatotrophs. That's why it's called somatostatin as well. And that helps the growth of the tissues, especially the long bones, linear bones. And then we have the gonadotrophins. These are LH, FSH, and these are secreted from gonadotrophs. That's why we have 5 cells and 6 hormones. So the gonadotrophs, there is acidophilic and basophilic secretes the LH and FSH. And then we have the lactotrophs that secretes the prolactin. Okay? Right, so the hormone receptors can be, the hormonal action mimic someone shooting a shoot to a target. So the shoot is the hormone, and the shooter is the gland, and the target are the target organs. And when the hormone reaches the target organs, obviously it gets attached to specific receptors, and then you have post-receptor signal transduction. So all the endocrinopathies are either high or low. And this low can be a true low in the secretion of hormones, or can be a pseudo low. So you have pseudo hypoaldosteronism, pseudo hypothyroidism, and pseudo hypoparathyroidism, etc. And the pseudo means that there is a problem in the receptor at the receptor level. So you have excess of the hormone, but it's not functioning. So in the high we find high hormones, in the low we find low hormones, and in the pseudo or relative low we find that the real hormone the hormone trying to stimulate the target organ is actually in excess but unable to work. And the problems, the hormonal problems, can be secretory problems from the gland, or can be at the receptor level, as we just seen in the previous slide. We have the shoot and the shooter and the target. So if you have a problem at the receptor level, then you have resistance. And if you have secretory problems, then you have deficiency, or you have secretory problem in excess. So then you have hyper condition of the endocrinopathy. And these problems can be congenital or acquired. So you can have congenital growth hormone deficiency, or you have acquired growth hormone deficiency secondary to road traffic accidents, for example, or brain tumors. And most of the pediatric diseases now have genetic and immunity relationships. So they have some immunological background or genetic background or predisposition. So the main topics in endocrinology are growth, puberty, diabetes, obesity, hypoglycemia, hypopituitarism, thyroid, adrenal, disorders of sex development, calcium and bone metabolism. Dyslipidemia is actually a metabolic topic. I'm not quite sure whether you're covering the metabolic with Dr. Serrar or not. لكن it depends on the area, whether it's tackled by the endocrinologist or the metabolist, but it's basically an enzyme based science more than hormonal related, and therefore historically they are not part of the endocrine disorders, but I just added them here in case you are not covering them. It's one of the important topics you need to cover in your pediatric revision. So you need to know about primary and secondary dyslipidemias, and the subtypes of primary dyslipidemia and the different causes of secondary dyslipidemia. What I'm going to cover today are the growth, the puberty. I will touch base on the diabetes, maybe the DKA if I find a chance. This is a different talk. I'm not going to talk about obesity. Hypoglycemia will be covered by Dr. Bashir Al-Wasila next Thursday. And hypopit is something we are going to touch base on, because if we talk about growth and puberty and thyroid and adrenals, we are more than halfway of talking about this, because we will talk about this at primary and secondary level. So by definition, we are talking about isolated deficiencies in these topics, and also the secondary include the secondary level of deficiency includes hypopituitarism. Disorders of sex development is a subcategory from the adrenal problems, but it can also result. It can result also from other from other pathogenesis, which we'll talk about. But the commonest type of DSD is congenital adrenal hyperplasia, which is belonging to the adrenal problems, and calcium. So I'll talk about DSD, calcium, adrenal, thyroid, and puberty and growth. And if I find the time, I'll talk about diabetes, and I'll leave the rest of the topics to be covered either during the MCQ sessions or separate talks by my colleagues next week. My talks here will be simple, contains a lot of photos and explanation and description of the pathogenesis and management, and also will include some MCQs at the end of each section, possibly, or most of them. Yes, Summer, عندك سؤال, you raised your hand. تفضلي. You raised your hand, يا دكتور سمر. Share via YouTube. I'm not quite sure how to share this via YouTube, but anyway. Summer raised her hand. Do you have a question, or are you able to open your microphone? طيب. If you are able, interrupt me. Huh? And I will just carry on with my slides. طيب. Okay. طيب, let us start with the growth and puberty disorders. طيب, خلينا نشوف الكويشن عن مين اللي عنده رابط اليوتيوب لو ممكن. كلها يعني connection. I don't have nothing to do with that. Maybe Dr. Mohammed Zain can deal with that. We don't have microphone. So do I need to open them? Open the microphone يا دكتور محمد. هل أنت معانا ما زلت؟ محمد الزين؟
أيوة دكتور أمير, I will open for you المايك للناس اللي بيرفعوا يدهم if they want to.
أيوة. كويس.
Okay.
في الآن واحد اسمه سمر ما أعرف قالت شوف whoever raise يعني تابع لو في حد raised her or his hand. كويس.
أيوة.
want to interrupt with the question خليهم أديهم فرصة طوالي. I will pause and answer the question.
Okay.
ممتاز. يلا we'll carry on. So I'll start now with the growth and puberty disorders. طبعا التوبكس دي طويلة شوية عشان كده أنا هتكلم بسرعة شوية. كويس. If you cannot follow me, برضه this is enough reason to ask me to repeat if you wish. تمام. SMS question and answer. That's they said they will contact me through that. Okay, that's fine. Fair enough. طيب الآن you can see the growth chart on this side, and then you see the axis here. As I mentioned, starting from the even higher than the hypothalamus, there is central nervous system control, and there are some positive or excitatory and negative and inhibitory stimuli to the hypothalamus. Then this is reflected on the anterior pituitary, which send messages to other glands. طيب, if we ask a question, is this girl short? So obviously, we cannot answer this question without knowing how old is she and from which background she is. I mean, in terms of her father and mother height. So we know her family target potentials. So we know the mid-parental height, and then what are her family target potentials. We'll talk about this in a minute. So it's not easy to answer questions sometimes without background information. So it will be a matter of guessing. We'll come back to this scale again later. So that tells us, we have the centiles, and we have to, the best option is to have population-friendly centiles. So if you have these centiles from America, for example, that means you are comparing Sudanese children with American ones. If you use it in Saudi Arabia, the same. If you have Saudi charts, then that's more population-friendly charts. But they can also have some problems if there are some secular trends and changes in the population, and this is not updated. So every now and then, so every, say, 7-10 years, you need to update your growth charts because there is secular trends and changes in the body build of patients in different populations. If we talk about the standard deviation, then obviously you know more than 2 standard deviations. That's as per Bell chart means the patient is outside the normal zone. And so the gross short stage is defined as more than 2 standard or 2.5 in some literature find percentile, 2.5 percentile, 3rd percentile, or more than 2 standard deviation below the mean. So this mean needs to be the appropriate mean for this population, for gender as well. So that's why you have boys chart and you have females chart, and chronological age. Okay. So investigation of children less than 2 standard deviation reveals about 15% of pathology. But when the children are very short, less than 3 standard deviation of the mean, this will identify almost 60% of pathological cases. So that means as you go far from the mean point, that will make you more likely to have a pathology. Compare the child's height with the length of the population, as I mentioned. If you don't have a population-friendly chart, then obviously you need to know your population better. So even in for example, in Saudi Arabia, the charts here, there are many hospitals, they don't like to use them because they think they are out of date and needs to be updated. But we know that girls in Saudi Arabia will be within acceptable height by the society if they are not shorter than 150 centimeters, and boys 160 centimeters. These may not be determined the targets in Sudan. So in Sudan, for example, the girls may not be less than 160 or 163 or something, or 5, and the boys will not be shorter than 165 or 170. So I think you need to know your population by experience, and possibly if you contact the team with Professor Mohammed Ahmed Abdullah, they have their own obviously standards in mind. Dr. Selwa, Dr. Arij, Smahan, they will tell you and give you a lot of tips, obviously from their building up experience of knowing their patients better than us. And these are the CDC. These are the Child Development Center, or chronic diseases, communicable diseases have these charts in America. These are ones for girls. طيب مين قال chat هنا؟ في حد قال chat. Okay, Dr. Muhammad, we need the pediatric, so these are not belonging to me. Anyway, طيب. So short stage is divided less than 2 standard deviation, the velocity as well. So it's not only a one visit that will tell you that this patient growth is going right or wrong. You need to see the patient for the second time. So a second visit is very important in growth assessment, because you will see how much the child grown in the last, for example, 3 months, 5, 6 months, 1 year. And the growth velocity is measured per year. But even if you see the patient is 6 months and he grew 3 centimeters in 6 months, that means if he follows the same pattern, this patient will grow for 6 centimeters per year. So 6 months appointment will also give you a clue. So this is important, because you may see a patient normal now or within normal, but this patient growth is drifting away, so dropping down. And this happened after an accident or observation by parents, because this patient had road accident or brain tumors or whatever. Height of a child must always be defined in the context of genetic potential. So maybe he's coming with a short family, okay, and they want him to be taller than the average, even in the society. But this has to be taken into consideration. Even in the history, if there are some remote members of the family who are short, this has influence on individual members of the family. Failure to thrive is something different. So many patients come to us as gland doctors because of, sometimes they say he has an enlarged gland, and this is usually confused with hematology oncology. So they mean the lymph nodes. And also they send them over sometimes when they have mixed problem of weight, height, and head circumference. And this is a failure to thrive issue. So the patient may have other hidden pathology and not pure short stature, and this should be tackled in collaboration with other specialists. طيب احنا قلنا I mentioned that it's important to know the mother height and the father height, and in the context of that you decide this child is going the right direction or not. Is he short, going to be short or not? ما أعرف أنا عندي هنا موجودة شكلها ما موجودة. I need to go back. Sorry. طيب ليش هذا؟ Sorry. It's not there. So there is a slide, I'm not quite sure it will come later, where you can decide for family target potentials by measuring or calculating the mid-parental height. في واحد فيكم يقدر يقول لي يعني how you calculate the mid-parental height in a very brief way عشان تكون easy شوي يكون interactive السيشن.
الشباب those who are interested they raise their hand عشان نقدر نفتح لهم المايك.
يلا يا شباب ما تتهيبوا عشان انا يعني specialist في in this subject. Good. في واحد raised hand.
دكتورة تقوى تفضلي دكتورة تقوى.
Okay, assalamu alaikum. If the patient I deal with is the male,
No.
I will subtract the height from the father height and
No.
add. I will not subtract. I will add the mother and father height and add 6.5. If it is a female, I will subtract the 6.5 from mother and father height.
ممتاز ممتاز. طيب very good. خليكي معايا خليك معايا. هو شوف الآن في طرق كثيرة. أنت ممكن تقول مثلا I will add 13 كويس يعني mother or father height and add 13 to both of them وبعدين divide by 2 كويس. وممكن أنت تعمل الميد بوينت وبعدين you add or deduct 6.5 اللي هو يعني نفسه هي 13. وفي ناس بيقولوا 7.5 عشان تكون 14. It doesn't matter 13 or 14 ولا 6 ولا هي الايديا عشان ما تنسوها دائما انك if you are doing the mid-parental point or height for a boy then you need to make the mother height like a man height. So you add this 13 to the mother height, then you make it like the father and then you get the midpoint. And if you want to make it for a girl then you deduct the 13 from the father height. So you make his height as a woman height. And then you get the midpoint between the corrected height for the father and the mother one. And by this, you know, this is why called mid-parental point. يعني بتصححوا للfemales وبتصححوا للmales according to the opposite gender of parent. واضحة؟
Yes, clear.
Clear. هذه طريقة سهلة في إنك تتذكرها يعني أسهل ما تتذكر رقم. زي ما قلت لك يعني لو أنت عملتها from 13 ولا 14 or even 10 الأرقام بتجي متقاربة. After you get the point, then you add to this 8.5 or 10 برضو. يعني مثلا if you want to be accurate, you add and deduct 8.5. لكن if you add 10, it's easy. يعني أنا مثلا we take a mid-parental point of this boy or this boy is 150. That means this boy height is acceptable between 140 and 160 in terms of his family. كويس يعني الفاميلي تارجت بوتنشال بتاعته ازيد وانقص ب10 من الميد بيرنتال بوينت. These are the family target potentials. واضح؟ محمد عبدين تفضل.
Yes.
دكتور محمد في محمد عبدين ده لسه سؤال.
تفضل يا محمد المايك از اوبن.
السلام عليكم. ايوه بس انا كان داير اقول نفس النقطه اللي كان اتكلمت عنها دي. الميد بارنتال هايت فور بويز اند جيرلز.
نعم.
يعني corrected mother height plus father height for boys. Corrected mother height, corrected father height plus mother height for girls.
ممتاز. يعني هو ده this is the easiest way to remember it. كويس لأن يعني كده أنت it makes sense إن this is a mid-parental point. Okay. والفاميلي target potentials are around this. However يعني تذكر إنه ده ما the most important in making a decision to give treatment or not. لأنه أصلاً يعني sometimes some children may have influence from remote member of the family. جدته. كويس أو خالته أو عماته. كويس. فذات's not a rule انه يعني just تحدد الفاميلي تارجت potentials according للfather and mother the father and mother height. اوكي طيب carry on. طيب عندنا برضو الجروس velocity is variable. That's very important. عشان كده في حاجه اسمها جروس velocity chart. شوف الجروس velocity الان وين اشوفها هنا ما موجود عندي في سلايدز ما اعرف موجوده عندي. طيب anyway في الفيرست يير انت بتشوف انه بيكون في لو عملت velocity chart تلقاه عالي جدا وبعدين بتلقى واحده سمولر شويه بعدين تلقى ثاني علو اقل من العلو الاول. اكشولي العلو الاول هو ده اللي هو 1 year بيكون في gain of 25 centimeters. طيب وبعده في السكند يير 12 centimeters. في الفيرست 2 years ده this is a big jump in the gross velocity or infantile jump. And then you have the growth rate is 5 to 8 حتى في الثيرد يير هنا كاتبينه انه شويه زايد لكن بعد كده until puberty بيكون 4 to 8 او 4 to 7 centimeters per year. And then after that you have a growth spurt. والgrowth spurt اقل من الانفانتايل height gain اللي هو كم؟ تكون 8 to 12 centimeters يعني about 10 centimeter on average. اللي هي بتتاخر في البويز بتكون at around the stage 4 of puberty وبتكون earlier كويس في الجيرلز عشان كده the girls end up shorter than boys. So they have the growth spurt later by almost 1.5 to 2 years وبتكون higher شوية كمان the growth spurt in boys. So that means إنه in terms of growth velocity أكبر velocity موجودة وين؟ في الانفانتايل period 1 to 2 years. بعدها في slowing down شوية until puberty وبعدها عندنا another spurt during puberty أقل من الانفانتايل one. ممتاز. Another very important point أنا ما I will not cover every point mentioned in the slides لأنه المعلومات كثيرة شوية كويس اللي هو a change in the standing height كويس ده هو بسموه height لكن if you measure someone lying down this is called the length. This is typically done for children up to 2 years of age or children who have disability and they are measured by infantometer. And we have for the standing height we have a stadiometer. And sometimes if we don't have the stadiometer, you can measure them against the wall. Yes? And we have some stadiometers fixed against the wall. This is called, these are called wall-mounted stadiometer. Right? So this is telling you the same about gross velocity. However, the control of growth in infancy by nutrition mainly, and then by growth hormone IGF-1 axis. In childhood, growth hormone IGF-1 axis, and then also thyroxine has got a major role. Thyroxine is also important in other parts, but number 2 in childhood period. And then during puberty, the growth hormone IGF-1 axis is the main with the help of sex steroids, which help the growth of the spine. This is just telling you about the different levels. اللي هو growth hormone is directly working on liver to change or to help it to produce IGF-1 that works in the growth plate, in the receptors in the growth plate. So you have IGF-1 effect and you have growth hormone effect. And you may have in the resistance problems with IGF-1 or problems with growth hormone receptor, these in Laron syndrome and syndromes that in which you don't have good response to growth hormone. So if we talk about the etiological causes of short stature, and the history and examination is guided by this. At postgraduate level, you have to guide the history or history taking and examination by the etiological causes and the pathophysiological causes, because this will tell the examiner that you are asking about specific questions and it's not just random and routine way of taking history or examining the children without any clear purpose. So the short stature can be non-pathogenic or pathological. So the non-pathological one is the constitutional delay of growth and puberty and the familial or called genetic short stature. And the difference between them, the constitutional, اللي هي تركيبي. It means that this person has got a delay, تركيبي في جسمه في growth and puberty, but they catch up at certain point. This constitutional delay can be isolated in growth only, or can be in puberty only, but commonly they are together, constitutional delay in growth and puberty. So the commonest cause of short stature in boys, almost 90% of short stature in boys is due to constitutional delay and of growth and puberty. If you see a short girl, and pronouncedly short, then obviously you have to think about Turner and the karyotype and whatever. So you have to look actively for a cause, not like in boys. Familial short stature is a genetic one when both parents and number of family members are short. So there are some genetics of short stature, and this is mainly in the growth plate site, not at the growth hormone secretion level. Skeletal dysplasia, so this is also bony problems. So this is one of the pathological. Intrauterine growth restriction or retardation and genetic disorders. So like in Russell-Silver syndrome, in patients with something called triple M syndrome, different causes of IUGR can result in or sometimes called small for gestational age. There is difference in the between two terminologies يمكن في neonatal session أخذتوه. لكن بالنسبة لنا إحنا interchanging terminologies here. When we say IUGR or say SGA, it means the same category, that this is a patient who did not catch up at the time of by 2 to 4 years, depending on whether you are following American or British school. So they can be non-syndromic or can be syndromic. Then systemic disorders, chronic illnesses. So chronic illnesses, especially the renal, chronic renal failure, and the gastrointestinal. So the inflammatory bowel disease or celiac disease malabsorption. But other chronic illnesses like asthma or cardiovascular also can result in stunted growth. Then we have endocrine causes, okay? So these are the causes of short stature. Non-pathological, constitutional and familial. Pathological, skeletal dysplasia or chronic illness or IUGR, syndromic, non-syndromic, or endocrine disorders. So this is a difference between the familial and the constitutional. The constitutional catch up, but the familial continue to be short. If we talk about the endocrine causes, there are 4 major ones. These are the growth hormone deficiency, hypothyroidism, so thyroid hormone deficiency, and panhypoparathyroidism. Sorry, pseudo hypoparathyroidism. That means there is excess of PTH but not working, as I started my talk with. Sudo Hypoparathyroidism. So excess of PTH but not working at the site, at the target organ. So all of this, so you have 2 of them are deficiency, growth hormone deficiency, thyroid deficiency. Glucocorticoid excess is a Cushing syndrome. In fact, Cushing syndrome results in short stature by early fusion of the growth plates. So this usually have advanced bone age to start with, between maybe 6 or 7, depends on when it appears, until 10, and the child may be taller than his mates. But this child will have closure of growth plate earlier than the others, so he end up short. So glucocorticoid excess, Cushing syndrome, the child can look taller than the others in certain age, but the net result is that the child is short. Then we have pseudo hypoparathyroidism. They have Albright hereditary osteodystrophy. This is a features, the morphological features are called like this. When they are short, rounded face, and they also have, what do they have in their hand? Common question there. جيبوا دايما في الفوتوز وجيبوا في الquestions.
Dr. Amir, we have one question.
أيوة.
Dr. Arwa is asking about what is, just a second.
طيب أشوفه الآن هنا مكتوب ولا في الشات؟
طيب في الشات
ممتاز، جاوبوا كلهم قالوا short, fourth and fifth metacarpal. Very good. This is what they have in pseudo. Excellent. Yes. طيب تفضل قول الquestion.
What is the reliable bone age to say this is constitutional delay?
بحاجة أتكلم عنها حسي الآن. أنا حتكلم عن إنه what are the causes of delayed bone age. طيب يعني you don't need to be too detailed لأنه دي very specialized إنك تعرف what degree or what age usually. طبعا the typical course of constitutional delay إنها تحصل between the age of 5 to 9 or 10. فبكون في constitutional delay in this time they notice إنه child is short. بعدين they start to catch up around 10 years 11 years فبيبقى في approximation of the bone age at this time. قبلها لو عملتها between 5 to 9 delayed. اصلا ال causes of delayed bone age are like this. If you have delayed bone age for the sake of MCQs وكده, this is endocrinopathy or constitutional delay of growth and puberty. الباقيين ما فيهم delayed bone age. لكن practically if you have severely يعني affected patient with a chronic illness برضه ممكن يكون زي malabsorbing child will have also delayed bone age. ويعني if you have hypogonadotrophic hypogonadism because you will have delayed bone age. لكن for the sake of exams you need to know إنه the causes of delayed bone age هم constitutional delay of growth and puberty or endocrinopathies. عاوز واحد فيكم يقول لي which one of the endocrinopathies ما associated with delayed bone age. ذكرته أنا الآن. mentioned. نشوف في الشات في ناس متابعين كويس. مع الهايبوثايريدزم أبدا. الهايبوثايريدزم معه delayed bone age. مين اللي قال لك؟ CH مين اللي قال معه شورت؟ كوشينج excellent. إناس تسنيم محمد ممتاز. كوشينج syndrome لأنه بيعمل advanced bone age وبيعمل early closure. So this is not associated with delayed bone age. ممتاز. Increase cortisol. Excellent. Let us move forward. طيب now if we say this is short ولا لا عرفنا الage بتاعها we are going to plot her height in centiles. We'll go the family target potentials بتاعتها مش كده. We are going to examine her. She's short and obese ولا short and thin and slim. obese مش كده. وده بيمشي مع الاندوكراينوباثيز ولا لا. يعني انا لو حسي رجعت للكوزز هنا كويس different causes. تفتكر اللي بيكونوا short and obese مين؟ الاندوكراين. طبعا ده اللي عندهم chronic illness بيكونوا عادة short and slim الا يكون عندهم water retention كويس زي renal ولا cardiovascular whatever liver disease. السكليتال dysplasia بيكونوا disproportionate والاي جي ار بيكونوا consistently small كويس. والconstitutional delay of growth and puberty بيكون عندهم pubertal delay. تمام. This is يعني pathognomonic الاشياء دي. فدي اقرب لانه يكون عندها endocrinopathy because she's short and choppy. طيب evaluation of short stature قلنا احنا already according to the causes. انا ما حمشي through this كويس لانه you need to map this in your head. Since انه الكوزز اللي احنا قلناها دي معناها انا اصلا لو ده اسال عن الفاميليال والجينيتيك والكونستيتيوشن هسال عن ايش؟ هسال عن انه who else is short in the family. When did they pick up in terms of puberty? Is there anyone who had family delay in puberty in the family ولا لا؟ مش كده؟ ده اسال عن proportionate ولا لا؟ هقول لهم what sort of clothes التوب and the lower clothes بتلبس ولا بيلبس عمر كم؟ يقول لك فوق بيلبس كده وتحت بيلبس كده. تمام؟ جيت مثلا مثلا chronic illness does he have يعني have any known diagnosis ولا عنده any diarrhea constipation whatever. does he have any renal problems كويس asthma etc. any chronic illness. كويس. جيت اسال عن الاي جي ار small progression birth weight. طيب birth weight هو بالنسبه لي اهم شيء. عاوز اسال عن مثلا الاندوكراينوباثيز بسال هل عنده اي يعني other child in the family treated with growth hormone deficient في any history of head trauma حصل. is he wearing glasses or not. see features of hypothyroidism constipation etc. كويس. features of Cushing syndrome whether he put on weight suddenly ولا لا. does he have any tetany etc. this is for the pseudo hypoparathyroidism. كذلك evaluation for any systemic illness for any exogenous administration of steroids that can give Cushing. كويس. psychosocial milieu يعني it has got any psychosocial distresses that can result in failure to thrive and height is part of that. Neurologic symptoms, visual or headache, so indicates any tumor or anything affecting the pituitary. كويس. ودي كلها في الهيستوري. examination the growth parameters كلها والarm span so you need to know whether this patient is proportionate or not. طبعا ممكن يكون عنده short arm span ولا lengthy one like المارفان في التول stature وممكن يكون عنده يعني rhizomylia as in achondroplasia hypochondroplasia ممكن يكون عنده يعني lower body segment if there is disproportionate because he's got lordotic posture, he's got any scoliosis, etc. He has pigmentation in the skin, maybe part of neurofibromatosis, etc. Nutritional state of the patient for celiac, etc. Dysmorphic features, Turner staging. So if she's a girl, she has got any features of Turner syndrome. The puberty is important, as if there is delayed puberty, going with constitution, etc. Neurological examination and fundal examination, as well as assessment of the thyroid gland. So this is how we mentioned the target height for child and mid-parental height measurement. Sometimes this is described in inches. So you need to be familiar as well of how much the inch is per centimeter. Type baseline investigations for short stature. Well, short stature is a lengthy topic. Others will go quicker شوية. لكن one of the challenging ones. Baseline investigations. طيب أسهل عليكم. دقيقة نشوف في هنا chat and question. The CH causes advanced bone age. حنجي نتكلم عن CH يعني احنا كويس. انت يعني في رايكم CH ممكن ولا لا؟ سحر. If you don't know, you ask the question, maybe assuming that you don't know. يعني هو انت الان الاندروجينز كويس ممكن yes. الاندروجينز كويس androgens cause advanced bone age but to certain limit. عشان كده البيشنتس اللي عندهم pseudo puberty they do have some advanced bone age. But يعني this usually will not affect the final adult height. لكن احنا البون ايج ده الان خلينا نحطه في الكاتيجوري بتاعته. In terms of short stature, you need to know انه the causes of delayed bone age are endocrinopathies with the exception of Cushing and constitutional delay of growth and puberty. These are the most important information. الادفانس بون ايج ده موضوع ثاني يعني ما بيسالوكم منه كثير as general pediatricians. طيب I'll come back to this. انا هخلي الشات ده مفتوح هنا شويه عشان لو في حاجه اشوفها او بشوفها هنا بيظهر. طيب الانفستيجيشنز للشورت stature you can summarize them as follows. You need function tests for many organs. طيب الفانكشن تيست دي كلها لانها affecting the growth hormone pathway or affecting the growth يعني the thyroid مثلا. So you need blood function test. ما في حاجه اسمها blood function test لكن هي شنو؟ full blood count ESR for the malabsorption كويس celiac. You need renal function test لانه chronic renal failure one of the major causes of short stage. You need bone function test لانه فيتامين دي والريكيتس كويس والسودو هايبوباراثايروديزم كويس دي causes. You need thyroid function test because thyroid affects the growth. You need liver function test لأنه liver function test in the pathway of the growth hormone. This is how the IGF-1 is produced. So now blood function test, renal function test, thyroid function test, liver function test, كده kidney function test. And then in addition to that, in any girl, you need the karyotype because there is a spectrum of presentations for Turner syndrome. And you need to rule out celiac disease, so you need celiac screening, and the ferritin is part of that. You don't need the skeletal survey as a routine if the patient is not dysmorphic or looking as having striking dysplasia. So this is required for skeletal dysplasia. The bone age is complementary because it tells you whether it's delayed or not, and it's delayed in constitutional delay and endocrinopathies. Further investigations, level of IGF-1 and IGF-PP3, the binding protein. This is a bit detailed knowledge. You don't need to bother yourself with that. There is also provocation, growth hormone stimulation test or dynamic test. And this tells you about the response of the potential response, growth hormone secretory potentials in the body of the child of interest. طيب دي بس صور عشان تديكم فكرة كويس. الآن this is the mother and this is the child. So this is the mother with growth hormone deficiency. Very severe. This is what? Small for gestational age. So it may have potential catch up by the age of 2 or 4 or not, and it may be a candidate for growth hormone later. This is a patient with malabsorption. ليش؟ لانه if you look carefully you will see that انه الصور بتاعتي دي عامله شويه هنا كويس انه he's not fully pubertal he's 15 so he's got delayed puberty and also demaciated and also he has got a falling of height. So this patient has got a defective growth in weight and height and puberty, and this is part of inflammatory bowel disease. This is Turner syndrome, classic features of webbed neck, shield chest, so the nipples are distant from each other, and then you have low hairline, and you have the features of increased carrying angle. You will have, what do you have in the heart? What do Turner patients have in the heart and Noonan have? Noonan syndrome patients have what? And Turner patients have what?
They are answering coarctation.
Coarctation. So good. So left-sided lesions are in the Turner syndrome. Right-sided lesions in Noonan syndrome. So if they give you pulmonary valve or pulmonary artery, peripheral pulmonary artery, stenosis.
They are answering pulmonary stenosis in Noonan.
ممتاز. Excellent. Excellent. So خلاص this is a golden rule انه right side lesions مع نونان والleft مع تيرنر. I'm just checking on the progress of the course يا دكتور محمد.
تمام دكتور تمام.
كويس. طيب النونان سيندروم طبعا واضح انه بيكون عندهم ايش؟ طبعا برضه التيرنر سيندروم ده واحده من الاشياء المهمه انهم prone to develop what؟ يعني لو جاب لكم في MCQs وكده. Turner they usually have infertility لأنهم عندهم primary gonadal failure. They have streaky ovaries. They are prone to develop diabetes, celiac, thyroid. تمام? Also Down syndrome is similar to them. Also prone to develop diabetes, thyroid, and celiac. So this is required in their screening. تمام؟ طبعا Turner syndrome is what? Is a chromosomal problem. It's an XO. مش كده؟ X0. Noonan syndrome is what? It's an autosomal dominant problem, can affect the bones, it has certain gene. تمام؟ they are similar في features انهم عندهم web neck, they have heart lesions, they are short, yes, but the pathophysiology is different. They do have drooping eyelids like this. Okay? So this one is stunted, very short, usually with growth hormone resistance, Laron syndrome. Okay, I'll move forward. طيب FDA approved indications for hormone therapy طويلة, لسه طويلة. You need to remember from them 4. Growth hormone deficiency, IUGR or SGA, chronic renal failure, and Turner. في rare condition اسمها SHOX gene deficiency اللي هي دي واحدة of the dysplasias very similar to Turner, has got specific features. في حاجة اسمها Madelung deformity. You don't need to bother yourself with that. Noonan is also additional indication idiopathic short stature, but approved universally هم الفور ديل الأوائل. كويس. Idiopathic if we don't find a real cause, لكن the patient is short. Prader-Willi syndrome is indication in some countries. It's very useful, لكن it's not given for mainly 30% are growth hormone deficient. لكن they all need it because it improves the body composition. The growth hormone reduces the fat component and increases the muscle and bone. عشان كده مرات الاثليتس لما يقدروا يغشوا مثلا في الكومبيتيشنز تلقاهم مرات they inject growth hormone, بيعملوا لهم تيست عشان يشوفوهم هم they are having artificial boosts ولا لا. ومرات some people برضه misuse it من الادolescents عشان يقووا المسلز بتاعتهم، تلقاهم بيشتروا growth hormone and injected locally in the muscle to improve their muscle build. والبرادر-ويلي عندهم بيكونوا جسمهم بيكون تعبان هفتان كده لانه عندهم fatty tissue كثير، this will improve their body build. لكن it was associated with some suffocation and يعني in some countries في some reports عشان كده في some countries are skeptical about prescribing it because it may result in enlargement of the adenoids and blockage in the upper airway obstruction. Adult growth hormone and AIDS wasting these ما في داعي نتكلم عنها. طيب side effects أهم حاجة إنه أهم حاجة في السايد effects شنو؟ في الجروث هرمون. واحد يجاوب، واحد يعطينا إجابة. يلا. benign intracranial hypertension. كويس. This one pseudo tumor cerebri. لأنه benign intracranial hypertension, very good hypertension إسراء. It's not the pseudo tumor cerebri. It's not a benign actually. If you leave it, it will result in blindness. So if you suspect it, you have to work on it and examine the back of the eyes. لكن it's very rare. I only saw it in the UK. ما شفتها خالص. في السعودية شفتها مرتين. شفتها لأنه this is a big tertiary hospital. ويعني طبعا relieved by frequent CSF drainage. وبعد ذاك we put the patient back on growth hormone in a smaller dose and never developed it again. So it's not something, it's not an absolute يعني contraindication forever. But it's obviously if you suspect it, you better hang up your treatment. Hypothyroidism عشان كده بنعمل لهم thyroid function test. Insulin resistance عشان كده بنعمل لهم A1C. So growth hormone is one of the counteracting hormones to insulin طبعا. بعدين عندنا sleep capital femoral epiphysis وscoliosis. This can happen. Gynecomastia can happen as well. في أشياء إحنا لاحظناها ما مكتوبة هنا زي it induces migraine in some children whatever. يكون عندهم أصلا. So development of cancers ما في evidence growth hormone is carcinogenic. However, you need to be careful with the patients who had surgery recently, brain tumors, and the consensus is to give them growth hormone if they need to, especially if they have craniopharyngioma and their pituitary has been removed, to give them growth hormone, but after 1 year of the surgery. وإذا كان يعني البيشنت leukemia, all these patients, obviously that's not a contraindication to give growth hormone. لكن بالذات the solid tumors, if there are patients who have risk of solid tumors like Fanconi anemia, whatever, then you need to be careful with that. And if you're not desperate for the growth, you shouldn't use it as a ledger treatment. But there is no evidence that it's carcinogenic. طيب tall stature in brief. لو سألتكم إيش الديفرنس بين التشالد والتشالد الآن؟
Dr. Amir, we have one comment from Dr. Aresha. She is asking about link of growth hormone and stroke.
Stroke. يعني ما في direct link. يعني إنه it's not it doesn't lead to thromboembolic phenomena. لكن لو benign intracranial hypertension حصلت and it is not treated, one of the complications غير blindness, it may lead to neurological complication. However, growth hormone is not something related. يعني ما عنده coagulopathy, tendency to coagulopathy patients اللي بياخدوا. شفتي patient انت with stroke؟ No. Okay, good. طيب الآن احنا نشوف upper to lower segment, disproportionate upper to lower segment. أيوة ما ده يعني هو upper to lower segment ده clinical. انتوا شوف أنا cannot answer all the questions لأنه it's too detailed. أنا عارف إنه short stage وهذا is a lengthy one. عموما في حاجة مهمة. At age of 8 to 10 years مفروض الarm span يكون بيساوي الطول. يعني لو خليت واحد كويس stretch his arms you measure between the tip of the middle fingers بين الاثنين المفروض ده يكون قدر طوله 1 to 1. Before that عندها ratios ترجع لها في الكتب. شوفها كم 0.8 to 1 وشنو كده. فإذا لقيت واحد مثلا عنده الارم سبان taller than this زي ما قلت في البيشنت ده الآن ده عنده tall stature ومعه مارفونويد features. لكن المين ديفرنس بين الاثنين ده انه في one has got intellectuals normal اللي هو child is marfan والother homocystinuria بيكونوا developmentally delayed. Both of them have eye signs, symptoms or signs. ايش هي؟ واحد فيهم كلهم عندهم dislocation, tendency to dislocation of lens. واحد upward and outward, واحد inward and downward. كويس؟ عملوا check. This is exercise. I give it to you. Check it. Who has got upward, yes, and outerward dislocation of the eye lenses? Well, who has got, yes, downward and inward? بس في بعض الناس جاوبوا هنا. Check it.
upward.
طيب خلاص خلينا البقية to check that. I'm not going to talk about tall stage كتير لكن ده this is only a diagram which is useful way to classify problems. شوف history of physical examination stigmata. If the patient has got proportionate tall stature or not. If yes, this can be Bickwith-Whitman-Weaver syndrome. حصل عنده features that Bickwith-Whitman كويس single ear crease كويس وعنده organomegaly والبيشنتس اللي عندهم no proportion معناها ممكن يكونوا taller in the lower part or the head or the upper part of their body. Scoliosis syndrome, Klinefelter syndrome, guys, and those with estrogen deficiency resistance. But then patients who have, you assess the bone age. If there is no stigmata syndromic features, and if it is normal, then this is constitutional acceleration, not delay. This is wrongly written. Or accelerated bone age, then this can be with obese and non-obese patients. If it's with obese, then this is exogenous obesity, or we call it simple obesity. And if in non-obese patient, this can be growth hormone excess. If the patient puberty is fine, if it's advanced, this can be associated with hyperthyroidism. طيب سؤال عشان نشوفكم متابعين ولا لا. خلاص, this is the end of growth. In which of the following conditions is bone age consistent with chronological age, not delayed? ثلاثة familial, very good. قلنا severe dwarfism وchronic illness كويس. الجلوكوكورتيكويد excess كويس لكن ما نورمال صح، ما consistent. يعني اللي جاوب 4 ما صح لأنه هو ما delayed لكنه هو ما نورمال advanced، مش كده؟ advanced. اللي جاوب صحيح 3. You're right, excellent. طيب واحد جاوب دي. The 6-year-old girl short stature gross chart reveals the birth length at 60th percentile 6 years and a current طبعا ما في 60th percentile لكن المهم هو في النهاية between the 50th and 75th and the current height at 5th percentile. يعني ايش ده هسي؟ length 60th وشويس والcurrent height 5th. يعني في البداية كان كويس مش كده؟ بعدين بقى short. الجروث velocity in the last 3 years has been 3 centimeters per year. normal ده 3 centimeters per year ما normal. قلنا 4 to 8 مش كده ولا 4 to 7 ده suboptimal مش كده. وال3 بالذات لا 25 الرايت velocity المفروض تكون كثيره جدا. معناها البيشنت ده lost a lot of potentials. السبيرتا كان ممكن تحصل infantile period ما حصلت. her weight at the 50th دي كيف دي؟ short and obese ولا short and slim ولا normal consistently small؟ consistently small ده للاس جي اي. short and obese endocrinopathy. short and slim ده مع chronic illness. تذكروها؟ طيب there are no midline defects or dysmorphism. her bone age is 4 years. اي bone age عشان نعرفه delayed ولا ما delayed العمر إذا هو 2 years and more ده delayed. كويس؟ ب 2 years. less than 2 years معناه ما delayed. كويس؟ acceptable. The bone age compared to chronological. هذه عمرها 6 والبون age 6 sorry 4. معناه what is the most likely diagnosis؟ في delayed bone age. اختلفتوا اختلافا كبيرا. كويس؟ طيب الحاجه الاجينست الكونجنتال هايبوثايروديزم شنو؟ الويت؟ لا الويت ما اجينست. اوبيسيتي لما اصلا كلهم هم البوني الانتليجنس فيري جود اللي هو اي او ايفري ون قال الانتليجنس فيري جود وسيف برضه سيدي ممتاز كويس. النورمال انتلكشوال فيري جود برضه يا خنساء وزميلات ممتاز فيري جود كويس. الانتليجنس نورمال انتليجنس this is against congenital hypothyroidism. كرونز والباقيين زي ما قلت لك انا اهم شيء اللي عندهم delayed bone age for the sake of the exam هم الconstitutional delay والاندوكراينوباثيز. good. طيب we'll move forward ولا في question في الجروث؟ Is that useful to you ولا too advanced الكلام ده؟
They are asking about the answer of the previous question.
The previous growth hormone number 3. growth hormone deficiency.
ايوه اوكي they are saying very useful.
Very useful. Thank you. أنا شايفين ال contribution بتاعه ممتاز. طيب growth hormone deficiency قلنا لأنه we ruled out ال other endocrinopathy اللي هي لأنه في normal intelligence. ممتاز كده؟ طيب let us proceed to abnormal puberty. ممتاز. طيب ال abnormal puberty approach هنا بيعتمد على إنه to understand the physiology of normal puberty and then how to assess the puberty and then the deviation is either early or delayed. So you need to know في ال early causes, right? Or diagnosis, how you make the diagnosis or management. Right? Etiological. في different ways of classification there. طيب let us see. أصلاً normal physiology إنه في central nervous system control. طيب on the hypothalamus and then the hypothalamus has got a control on anterior pituitary. طيب nowadays we see different boys and girls because they have يعني different because pubertal ages. يعني مثلا ممكن تشوف الاثنين ديل هسه this is of Indian background, this Caucasian, this has got some chest development so she's growing, this one is still مع انهم the same height, this is obese and this is slim. كويس؟ انتوا you can see my cursor ولا you cannot see the cursor؟ بأشر عليهم ديل.
Yes, we can see the cursor.
Yeah. See the cursor. خلاص ف different ethnicities, different body build وكده. عشان كده timing of puberty dependent on genetic background, environmental factors, and the health, general health and body build of the patient. في ما أعرف أنا جايبه هنا ولا ما جايبه. في عندنا paper you can go back to this one in the Sudanese Journal of Pediatrics عن الكيسبيبتين. هي something called Kispectin, and this is a hormone. The Kispectin starts from here, from the nervous system, and can be stimulated by different stimuli, and this will trigger or mark the beginning of the puberty. It's a very important hormone for puberty starting in different mammalian in different mammals actually, so the human and also other animals. طيب فارجعوا للنادي كيسبيبتين و just Google it. It's my name or the Sudanese Pediatric Journal, you'll find it. The LH is far more important than FSH in marking the puberty. عشان كده early morning testosterone as well. So people measure the early morning testosterone in boys. This indicates that this patient is getting pubertal. And the LH is the one that marks the menstrual cycle in girls. So, and FSH is related to the breast development and also to the nutritional function in the boy's testes. So LH is the one which is more important in identifying puberty in boys and girls. And it has some surges like this fluctuation during the day. So this is midnight and in the morning. That's why associated with early morning testosterone. طيب لما نيجي نتكلم عن التانر staging, تانر هو بريتش يعني physician endocrinologist or تانر مارشال, في 5 stages of puberty. Each of them will take about 6 months to 1 year. So the puberty to complete will take about 2.5 to 5 years. طيب and these are looked at from one angle is as secondary sexual characteristics or primary sexual characteristics. The primary are the organs that are dependent on the sex hormones, direct effect by the sex hormones. And the secondary is by the adrenal gland. عشان كده كل secondary sexual characteristics اللي بيشوفها في البويز والجيرلز دي من الادرينال glands, starting from the mood changes and the sweating, the body odor, and the hair, in the axilla, in the pubic area, and the acne, and some contribution to the height as well. However, the breasts, the testes, and the penile, length and size, and the main effect on the bone, growth plate, these are direct effect by the main sex steroids. عشان كده if the main axis is involved at true puberty, you will find breast development and you will find testicular enlargement and so the pubic hair and the axillary hair and the other features are not conclusive of true puberty. Secondary sexual characteristics تبدأ بدري. So in different societies they have different ages. So you cannot say إنه المكتوب في الكتب ده يقول لك 9. طبعا مثلا في أفريقيا في Black American ده من very early 7.5 or 8. لكن what you study for the sake of the exam, less than 8 years in girls is early, okay, so early puberty, precocious. Or less than 9 in boys, this is precocious. طيب less than 8 in girls, okay. طبعا ماخوذة من societies مختلفة, European societies. برضو you need to refer back to your colleagues in endocrine there to tell you about the Sudanese girls and Sudanese boys. بعدين برضو في limit upper limit إنه if you don't have the signs of puberty, by which age you need to be worried, the delayed puberty ولا لا. Yes? يعني the agreed age is something between 13.5 to 14. طبعا for the period, the patient should have a period by the age of 15. If not having this by 15, it means there is delayed puberty or delayed menarche. She may have some other signs of puberty, but then she had arrested, what we call arrested puberty. So you need to carefully identify the beginning and the end. So you know what is early puberty and what is late puberty. تمام؟ طيب دي صعبة شوية. شوف الأسئلة. Clear. ممتاز. قالوا clear. Good. طيب مين ده هنا؟ طيب. طيب we have I mentioned this development of the breast whatever and menarche, age of menarche whatever. طيب بعدين in boys we have the enlargement of genitalia and breaking of voice, ده كله طبعا adrenal function. In both genders we have the pubic axillary growth spurt. طبعا بس حاجة مهمة أنبه لها, الأكسيلاري hair try to ignore it لأنه it's very أول شيء هو 3 stages only. طبعا في كل puberty staging هو بيبدأ من 1. It's not starting from 0. يعني التنر staging starts from 1. 1 means 0 يعني nothing. So if I tell you P1, it means there is no pubic hair. B1, it means there is no breast tissue. Okay, so there is no 0. If you say A1, because that means no axillary hair. A2 a little bit. A3 is a full. So it's only 3 stages. That's why it's not very useful. Well, it is racial dependent. So the patient can be hairy. So it's not very useful in the staging. The more important is the pubic, which has P1 to P5. Yes? While P1 is nothing, P2 is something around the labia or the scrotum, P3 is reaching the pubis, P4 is getting curlier, and P5 is having the adult shape, triangular shape. So reach the pubis by P3. Getting curlier, this is 4, a bit more dark and curlier. P5 is a triangular shape. B2 is around the scrotum and the thighs, but not reaching the pubis. Okay? طيب. Sex differences in puberty, المناركي قلنا يعني typically في certain age وقلنا السبيرماركي بيكون delayed. عشان كده growth spurt delayed in boys, that's why they end up taller. طيب الانيشال period of growth spurt whatever دي كلها ما حمشي فيها لأنها this is population dependent. ده الكلام اللي قلته قبل إنه normal puberty delayed ولا precocious. الآن ركزوا معي جدا لأنه حنتكلم عن غير definition of precocious وهنا اللي اتكلمت عنه. ده قلت إنه هو depends على البوبوليشن لكن يعني for your exam المكتوب عندكم مثلا في نيلسون وبتاع 8 years و 9 years. 9 years for boys و 8 years for girls. طلع من populations معينة. طيب precocious puberty اللي هي central or true puberty or peripheral. كويس؟ اللي هي generates independent precocious puberty يعني في secretion للتستوستيرون or estrogen from the ovaries ولا peripheral from a tumor أو incomplete or pseudo puberty. فعندنا true puberty, this is a true one من الأكسس كله أو peripheral يعني a true مرات بيقولها central أو peripheral اللي هي independent of the gonadotrophin لأنه في negative feedback mechanism. So they are independently secreting the testosterone and the estrogen and suppressing the gonadotrophin اللي هم LH and FSH. أو incomplete. طيب دي patient with incomplete. الانكمبليت بنسميهم premature thelarchy adrenarchy. It is thought to be إنه في oversensitivity of the tissue كويس to low levels of or normal levels of estrogen. أو oversensitivity also in the pubic area كويس to the adrenal hormones. That's why it's called adrenarchy or puparchy. Premature menarche is a very rare condition. I have seen كويس once or twice in my experience اللي هو بتحصل مرة بجلطة جي وبعدين تجيف تاني ما يحصل خالص. و it's not well known يعني the pathophysiology of this لكن it's thought to be full activation of the system for a short time and then disappears and then get deactivated again. تمام؟ So this is the incomplete puberty. Thelarchy, adrenarchy. طبعا you have to also know إنه يعني half or 2/3 ده بيجي في الMCQs كتير. 2/3 of boys have gynecomastia at birth. And one or مرات أسهل بيسهلوها بيقولوا half of the boys have مرات يكتبوا 2/3 half. شوف الليتريتشر عندكم ايش الريفرنس بتاعكم. 2/3 or half of the boys have gynecomastia during puberty. And half of them they have it unilateral. يعني half of the ones who have gynecomastia they have it unilateral not bilateral. So this is common in puberty in boys. تمام؟ طيب. الآن ده اللي أنا قلته true precocious puberty or pseudo. لاحظ إنه المتوقع شنو في true puberty GnRH is high والgonadotrophins are high. So gonadotrophin releasing hormone is high. Gonadotrophins are high and the sex hormones are high. لأنه ده axis is like this activated. وهنا لو pseudo there is peripheral secretion of the estrogen or testosterone and therefore giving feedback to the gonadotrophin and gonadotrophin releasing hormone. So you have the gonadotrophins and the gonadotrophin releasing hormone suppressed while the estrogen and the sex hormones and the estrogen and testosterone are high. So while the testosterone is high, it's called virilizing, and if the estrogen is high, it's called feminizing type of pseudopuberty. طبعا هنا true puberty can be idiopathic, can be due to cranial radiation, can be tumor, neurological, and can be priming. خلينا من priming ده حسي خلينا نتكلم عن دين. انت لو سألوك في اي سؤال في امتحان شوف these golden rules in etiology. اصلا etiological causes etiological كويس يعني the etiology of number of illnesses هي شنو؟ واحد إما تكون غير معروفة السبب idiopathic أو تكون physical trauma disturbance of the anatomy by trauma or tumor أو يكون في inflammatory process inflammation or infection. شفت كيف؟ أو يكون في infiltration by tumor. يعني أصلا الأشياء معظمها بتطلع من كده. في أي system endocrine or not endocrine لو سألوك من ideological causes think of these angles. اللي هي شنو؟ اللي هي idiopathic أو anatomical change due to trauma or tumor or whatever or irradiation or can be due to infiltration or inflammation or infection. Priming ده يعني ده حاجة بنعملها مرات لما نكون نعمل dynamic test so we give the patient before puberty 3 days doses of testosterone or estrogen and this will activate the axis temporarily. Forget about it لأنه ما حاجة مهمة لكم. طيب هنجي نتكلم عن حاجة مهمة جدا في السنترال بريكوشيوس والديلاي بيوبرتي. واحد يقول لي الأكثر البريكوشيوس بيوبرتي في البويز ولا الجيرلز؟ والأكثر الديلاي بيوبرتي في البويز ولا الجيرلز؟ تفضل مين؟ محمد ازاي معانا؟
ايوه they are saying the precocious puberty is more common in girls.
ممتاز.
while delayed puberty in boys.
ممتاز. Excellent. This is the answer. وهي ده عندنا شو precocious puberty more common in boys in girls كويس it is idiopathic with no cause. والdelayed puberty قبل قلنا ايش؟ the commonest cause of short stature شنو؟ البويز. constitutional delay of growth and puberty صح؟ معناها زي الايديوباثيك هنا. So idiopathic precocious puberty is common in girls. لكن مما تشوف precocious puberty in boys think of brain tumors ولا something affecting the axis. والdelayed puberty is commonly idiopathic أو constitutional عادية في البويز in 90%. فما تدعوك للقلق إنه هي delayed in puberty. لكن لو شفت delayed puberty in girls المفروض to think of ovarian failure, Turner syndrome ولا في حاجة. واضح؟ This is in general. لكن طبعا في other causes. So that's why we get central precocious puberty. كويس، ده كله ده كلام المهم في هذا الملخص اللي انا قلت لك ده اللي هو idiopathic اكثر في الفيميلز. بعدك they may have other causes like organic CNS disruption, cranial radiation, hypothyroidism. Interestingly في الام سي كيو ستدي hypothyroidism can result in hypo in precocious and in delayed puberty depending على الستيج بتاعه والسيفيريتي. اوكي طيب precocious pseudo puberty in females طبعا بعد ما قلنا الكلام اللي قلناه قبل شويه ده كويس central وperipheral كويس ده in general. طبعا انا لما قلت الان CNS disruption ده more common in boys والidiopathic more common in girls. ده في precocious puberty. انا بتكلم الان عن شنو؟ عن precocious not delayed. الان في approach ثاني. الابروتش الثاني للprecocious puberty pseudo or whatever is to find out انه the hormones causing these changes coming from where. فممكن انت تقول مثلا انه نمشي لدي اول اللي هي كده coming from the adrenal ولا from the gonad ولا exogenous. الان exogenous في حاجه اسمها environmental disruptors. يعني ممكن يكون البيشنت ده مثلا في بلاستيك باجز معينه ولا في اكل معين كويس. دي كلهم called environmental disruptors containing hormones and affecting the body build of boys or girls. تمام. sex steroids لو جايه الاكسس دي جايه from the adrenal ولا from the gonad بتفرق. الان لو جايه from the adrenal most probably دي congenital adrenal hyperplasia وده more common في الجيرلز كويس او adrenal tumors. ممكن يكونوا feminizing او يكونوا virilizing Cushing syndrome معه كويس. sex steroids from the gonads ممكن تكون ovarian cyst ممكن تكون testicular mass ممكن يكون Pachyonal Bright syndrome معهم ovarian cyst بيكون عادة not known how it happens although انه عندهم activation يعني overactivation of some hormones لكن they are prone to develop ovarian cysts كويس. وممكن تكون germ tumors germ cell tumors كويس. ممكن تكون في another organ producing testosterone or estrogen. نرجع الآن لديل اللي هو ده تقسيم isosexual ولا heterosexual. يعني لو حصلت في female والتيومر ده أو whatever the cause is causing more advanced puberty in a feminizing way like ovarian tumor, Pachyonal exogenous estrogen ده كله so called isosexual or feminizing. لو حصل masculinization opposite gender معناه ممكن يكون ده congenital adrenal hyperplasia, adrenal tumor or ovarian tumor secreting boy hormones. تمام. يعني in general الهيتيروسexual في الغالب بتكون جايه من وين؟ من الادرينال. والايسوسexual جايه من وين؟ من السكس اورجان. The same in boys. Isosexual كويس. هنا الايسوسexual from the ده في الجيرلز طبعا. هنا الايسوسexual from the adrenal gland لانه الادرينال جلاندز فيها ايش؟ فيها androgenic hormones يعني فيها boy hormones او male type hormones اللي هي بتعمل اكني في الجيرلز وكده. عشان كده الايسوسexual ممكن تكون جايه من السكس اورجان في البويز ومن الادرينال or heterosexual تكون جايه برضه من الادرينال ولا from exogenous estrogens. anyway التقسيم ده اسهل انك تشوف السكس ستيرويدز ان اكسس جايه من وين؟ من الادرينال ولا من الجونادز ولا from exogenous steroids. ده كله في السودو. طبعا في الترو بيوبرتي هتكون جايه من وين؟ جايه من السكس اورجانز طبعا لان دي ترو بيوبرتي. So you need the family history examination, cutaneous lesions like in Pachyonal بيكون عندهم cafe different from neurofibromatosis, fundal examination if there is any brain tumor suggest of central precocious puberty. You need head, height, weight and mid-parental height or gross velocity bone age, ternary staging, كويس. You need the baseline gonadotrophins and sex hormones. You need to test the adrenals as well, adrenal androgens. And you may need a dynamic test, gonadotrophic hormone test. ده طبعا biochemical. And then you need radiological. Radiological, you look peripherally and centrally. So you look at the MRI, hypothalamic pituitary region, and you look at the pelvic ultrasound عشان تشوف الجونادز وكده. Sometimes you need genetic test, as in testotoxicosis and a special gene, and as well as macular bright. And which gene is that? Which gene is the macular bright gene? جيناس gene. Excellent, Aisha. ممتاز. جيناس gene, جيناس 1. Yes. طيب. ايش القناة يمشي؟ طيب ممتاز. طيب ايش عندنا ثاني؟ So why do you treat patients for precocious puberty? لأنه لو جاتهم precocious puberty early, this will close their growth plates. So their final adult height will be short. So you need to prolong to stop the precocious puberty من إنها تحصل عشان the final adult height يكون acceptable. And also sometimes because they are premature in their mind, so this can affect their psychology and can give them psychological trauma. So these are the purposes of treatment of precocious puberty. If it is a pseudo puberty, obviously you need to treat the cause, whether there is mass or CH or whatever. Whereas beside managing the height well and the psychological trauma. But treatment بيكون بإيش? You give gonadotrophin releasing hormone analog. It's called Lebron. GnRH analog. ده هيكون like the key and the lock. بيقفل المكان اللي بيشتغل فيه الgonadotrophin, so there is no activation of gonadotrophin. LH and FSH will settle down and there is no production of estrogen and testosterone. Good كده؟ طيب. So you give that, ما في certain limit of that until you achieve this purposes of good height and also child is mature, so you get good collaboration and decision making with the family. Delayed puberty مرات بيقولوا عليها لو centrally hypogonadotrophic hypogonadism لأنه gonadotrophins ما secreted من فوق. أو لو كانت peripheral, so the hypergonadotrophic hypogonadism لأنه الgonadotrophins are not suppressed. Yes? But this is called the other name primary gonadal failure or secondary معناها central. Okay? طيب. Hypogonadotrophic hypogonadism طبعا usually قلنا delayed puberty معظمها في البويز شنو؟ constitutional. لكن ممكن تكون organic لو في hypothyroidism، لو في severe malnutrition، لو في optic dysplasia، لو في trauma radiotherapy، في tumor كويس، patient neurofibromatosis عنده مثلا optic pathway glioma، أو عنده hypothalamic hamartoma كويس. دي كلها كوز انها تعمل hypogonadotrophic hypogonadism في شنو؟ في البويز او هايبر او early puberty. طيب hypergonadotrophic hypogonadism in girls طبعا ده الكومون في الجيرلز انه يكون peripheral اللي هو تيرنر سندروم، او ممكن الاوفيريان فيلير يكون autoimmune of origin او due to chemotherapy in oncology patients or irradiation، او ممكن يكون مع الثلاسيميك patients due to iron overload toxic damage، او ممكن يكونوا اصلا disorder of sex development اللي هي complete androgen insensitivity syndrome اللي هو ده يكون اصلا patient who doesn't have sensitivity to androgens and his karyotype was genetically male but presented as a female because there is complete insensitivity to androgens. او patient عنده polycystic ovary syndrome. فدي كلها causes of peripheral type of delayed puberty resulting in hypogonadism due to a peripheral cause, therefore failure of response, and there is extra effort from pituitary to override this, so hypergonadotrophic hypogonadism. Hypergonadotrophic hypogonadism in boys can result from testicular damage due to in surgery or kidopixy or cryptorchidism or inertia, or in some syndromes like Prader-Willi, Lawrence-Moon-Beadle, or Noonan, okay, or Klinefelter, or gonadal failure with chemotherapy, etc. So it's usually something physical that affects the testis peripherally. But the commonest is to have constitutional denial hypogonadotrophic hypogonadism. But hypergonadotrophic hypogonadism in girls is common. So careful history, anosmia. Why do we ask about anosmia? For Kallmann syndrome. Okay, it's one of the causes of delayed puberty, central delayed puberty. Detailed toxology. Okay, both the growth, weight and height, كده, staging of puberty, general examination, the fundi. So you are looking for central and peripheral causes. And then you do also, like we did with the precautions, you do the hormonal workup, the endocrine, also that including thyroid function, including prolactin, because prolactinoma and hyperprolactinemia is one of the causes of delayed puberty. Okay, and you do the testosterone, estrogen, etc. You do the cortisol because you are testing the adrenal, okay, and the adrenal androgens sometimes. And then you do the dynamic test. You may do dynamic tests beside the GnRH test. You may need to do the HCG test, which is HCG is similar in structure to FSH and LH. So they share some group, beta group in the structure, and therefore can induce the same effect on the testes. And this will tell you whether this is functioning testes or not, especially if you have hidden genitalia and disorders of sex development. Karyotype is very important. And then radiological, especially in females, radiological level, you look at the pelvis and the head for the pituitary as well. And you induce it gently by testosterone or oxandrolone in cases of constitutional delay of growth and puberty. It can also be induced by estrogen, even in boys. But you can do that in girls if it's constitutional delay. But if the axis is affected and it's a central problem, then you need to give what we call maintenance hormonal replacement therapy in form of testosterone injections or estrogen, oral or patches or subcutaneous or creams. There are different formulations of this, so I don't need to get into the details. So this is just giving you the same photo earlier of Turner syndrome. They have hypogonadism. What type of hypogonadism? Hypergonadotrophic or hypogonadotrophic? Hypo or hyper? Hyper, very good. Hypergonadotrophic, very good. Hyper, excellent. Type. And and then we have this delayed puberty due to malnutrition, the body built, and this is Crohn's disease. And then we have Noonan syndrome. Also, they do have some sort of delayed puberty. Type. Okay, good. We come to 1:30. Seems we're probably going to finish the talk in the next session. It's like Dr. Muhammad.
Whatever you prefer, Dr. Amir, we have no problem.
Into what's their preference? أنا لأنه شوية هذا lengthy day كان، لكن خلاص أنا ممكن نكمل الثايرويد ونخلي الأدرينال and adrenal gland and CH and the bones نخليها في second session. So I start with them وبعدين دايشير الناعم take them into the MCQs. أفتكر الثايرويد is important. بعدين شوية heavy نديكم الجروث والdelayed والadvanced puberty والثايرويد فيها hyper. This is quite enough to absorb for today. لأنها شوية هي شوف أنت you need to make up your mind يعني الquestions بتكون كيف يعني شوية الاندوكراين tough subject بالنسبة لهم أنا أفتكر. I don't know what is their impression. Do you think it's tough or easy؟ يعني نشوف الإجابة بتاعته. How do you feel guys؟ tough. أيوة tough. فهو tough أحسن، في ناس قالوا easy كويس، لكن tough يعني thinking absolutely. فأنت you need to understand classifications pathophysiological process behind it عشان تبقى لك easy. هو it is not tough لكن شوية complex. إذا أنت فهمت فيزيولوجي كويس الأمور كويس. قال ظريف لكن في الامتحان طف. طبعا انت اذا فهمت يا اروى، اذا فهمته كويس في الامتحان ما بكون طف. الان انت لو جابوا لك اسئله اروى I ask you specifically، لو جابوا لكم اسئله في الجروث وفي البيوبرتي do you have a plan؟ يعني you can do educated guessing. الحاجه اللي انا هكلمكم عنها next time لما نتكلم عن التيبس. يعني انت
دكتور امير before the session ده هم they ask specifically انه
ايوه
they brought some questions about اللي هو extended matching question about a long acting insulin type mainly different brands. I think كان عندهم question
أيوة.
عن الدوغليداك وعن التريستا.
ايوه
واشياء ما هي familiar هم عليها هناك في يعني in our setup.
ممتاز. طيب انا بكمل الثايرويد بعد صلاه المغرب، افطر شويه كده الدنيا شويه وبعدين هعمل ايش؟ النكست سيشن نبدا بالديابيتس وبعدين نكمل بالليس فاميليار توبيك اللي هو الادرينال اند ذا بون. كويس كده؟
تمام.
فالان احنا ادينه كده شويه اصلي يعني we are back at 7 كويس 7 o'clock اللي هو هنا عندكم 6 نرجع بنشتغل الثايرويد والنكست سيشن بنشتغل الديابيتس اللي هو في الخميس الجاي نبدا بالديابيتس حتى بعد كده نتكلم عن الادرينال. الديابيتس نذكر فيه الاشياء دي كلها عن الانسولين والتايبس والاشياء دي يعني سيبريت دايابيتس اند اندوكراينولوجي زي سيبريت سبيشاليتيز هم بالحقيقه اثنين كبار شويه.
Dr. Amir, if you would like, if you prefer a thyroid برضه to be moved the second day برضه it's okay. يعني if it's
تبقى كثيره عليهم شويه عشان انا ما
خلاص اوكي.
هيكون في اذر سيشن
معناها ناخذ بريك for how many minutes؟
ايوه. في قال المغرب عندهم 6 و15 دقيقه عشان كده I think انه نحن we should be back by 6:30 عشان الناس يصلوا. كويس 6:30 عندكم اللي هو عندي انا 7:30 كويس واللي هو هنشتغل لحد 8 نص ساعه ثانيه بنكمل فيها الثايرويد. كملنا الثايرويد خلاص بيبقى معنا فضل معنا الديابيتس والريست اوف ذا اندوكراين سيشنز. انا اي ثينك انا يعني ما اعرف زي ماي اوبينيون طبعا كان انا بريفير تو دو ات ذيس واي لانه فهم الاندوكراين جزء كبير من حل الاسئله زي ما شفتوا انتم اثناء انتم بتشوفوا صم ماتيريال وصور واشياء كثيره واحنا انت يو هاف an imagination of the questions بيكون شكلها شنو. ده احسن من اديك اسئله ساكت وانت ما عارف التوبيك عن شنو مش كده؟
Yes. Okay.
طيب.
خلاص 45 minutes break we will meet at 6:30 خرطوم time.
باذن الله. جزاك الله خير يا محمد. بارك الله فيك. نفس اللينك يا محمد؟ نفسه؟
same link ايوه حيكون open اللي هناك حيكون open.
طيب.
We will not close. نفس اللينك you can join من نفس اللينك حق الايميل يا بوس.
ممتاز. خلاص انا هخلي اي شيء اوبن كده ستوب ذا شير ذات. طيب جزاك الله. السلام عليكم.